Well, good morning, Dr. Paul Corc. We're here with our pig who is live. We're going to do PPG, which is portal pressure gradient measurements, and we're going to ask you what PPG is. Dr. Corc.
Well, good morning, and thank you for having me, Phoenix, and all the AWE hosts. PPG is portal pressure gradient, but EUS PPG is a novel way to assess for portal hypertension using EUS instead of the more traditional percutaneous venous access approach.
Perfect. So it's a more direct measurement than what we can do with IR. We're going to ask you how we do PPG and what it is that we're looking at currently in the liver.
So what makes PPG very nice is, the patient's sedated like they would be for any EUS, so that they're not feeling anything, and it's a 25 gauge needle, so it's very easy to get access to the vessels. We basically are going to identify hepatic vein and portal vein and then take measurements from each of those vessels.
Perfect. That's how we're going to go through that. But as we're prepping the instrument and the device, can you tell us when you would do PPG?
That's a good question, because basically I would do it when the hepatologist wants me to. The real answer is that we use it a lot of times when there is a concern for advanced fibrosis, early cirrhosis, and we're trying to assess, for example, a patient's candidacy for surgery, perhaps for a weight loss surgery if there's obesity and fatty liver. It can be really helpful in those less common cases of trying to assess potential non-cirrhotic portal hypertension. And the advantage is, because we're doing an endoscopy, we can do all the other things that go with that. So we can do our regular endoscopic exam looking for varices or portal hypertensive gastropathy, and we can do our EUS exam if they have elevated liver tests. We're making sure it's not due to a biliary issue with our EUS exam, and we can take a liver biopsy at the same time.
So you went over the components of endohepatology. Can we go over the anatomy, what it is that you're looking at, and let's just demonstrate what PPG is. So
the pig anatomy, as I'm learning this morning, is a little bit different. These look like the hepatic veins, probably the left and middle hepatic vein hitting up to the left of the screen, and then we can identify portal vein as usually a kind of a brighter, more hyperechoic wall. So that looks like branch of portal vein. Usually in a human anatomy we can find the more central portal vein. I'm not really finding that as easily here. But the pig seems to have much larger hepatic veins than I'm typically used to seeing. So that should make it easier in terms of puncturing and getting access.
Perfect. Can we see the device or the accessory and the setup of it? We have our therapeutic nurse here, Jennifer, who's going to show you what it looks like. So this is the 25 gauge needle. It's made by Cook Medical that she's demonstrating here. And you'll hand it to Dr. Corc. So usually, if you do PPG, would you do it before or after the liver biopsy?
I do the PPG first, get our measurements, and then at the end of the procedure, take the liver biopsy.
Do you see significant bleeding associated with PPG, or is it the liver biopsy that you're worried more for bleeding?
Yeah, the nice thing, like I said before, this is a 25 gauge needle. It's the same as with the Cook needles that we're very familiar with. And even though we're going directly in the veins, I really haven't seen any bleeding. I think I've read one case report of some bleeding related to the PPG portion of the procedure. We do think about bleeding from the liver biopsy because that's using a 19 gauge needle, so obviously a much wider caliber needle, but it's still overall very rare. It's a very safe procedure. So
we'll have our tech Ramiro help with scope holding if you can. So once we're more stable, so if you're doing a patient and you go down and you see esophageal varices, would you continue with PPG?
That's always a good question. It depends on the clinical scenario. If we think they clearly have cirrhosis, they have the risk factors, you might not need to because they have portal hypertension then by definition. But if there's a question of non-cirrhotic portal hypertension, or if you're really just trying to assess get the gradient, maybe you want to use it to get a baseline. You could get a follow-up later if they're going to go on to beta blockers or something. That's probably a little more of an academic evaluation, but it could be useful.
Can you walk us through the steps here? Would you use color flow? Do you want to assess
I'm going to actually turn that off. That's nice for the viewers to see, but when I'm actually doing the puncture, I'm going to turn that off. I'm really just making sure I'm not going through any other vessels up top. You can see the needle starting to come out. I'm pretty convinced this is hepatic vein.
Any amount of liver you would like to have between the gastric wall and the vessel?
They do say to have some liver. I don't know if there's a certain amount, but as you're withdrawing the needle, then that liver provides some tamponade effect on the vessel, as opposed to just going straight into a vessel outside the liver.
So you're puncturing the needle.
I'm just going to jam it right through. I didn't necessarily have to because, like I said before, this is a pretty large caliber vein, but in the human they're a lot thinner. So sometimes we get access by going through and through and then sort of withdrawing the needle and then seeing it enter the space.
That's always nice because it tents on the one side and it's hard to get through into the vessel.
Correct.
So we go through to the other wall and then we come back into the vessel. So it looks like he's clear in.
So now we would flush to confirm that we see what we're seeing right there.
What is it that you're flushing with?
Heparin, 30, 29, 27.
So now Jennifer's reading out the numbers.
24, 23, 22, 20, 19, 17, 15, 15.
And she reads them just because the transducer is difficult for me to look down, and I'm keeping my eye on the needle because sometimes there's movement and you have to keep it adjusted so it stays within the vessel.
7.
So we can call that 7. So
at about 30 seconds when it's more stable, that's the number that we usually take, and then we do 3 measurements. But
yeah, so we can do one more. I don't know if we need to do all 3, but.
So you see the air bubbles as she's flushing. You'll confirm that you're in the vessel.
20, 18, 17, 16, 15, 14.
Do you recommend
9,
movement of the needle tip
9,
or you like to stay
10,
pretty steady? And
10.
I try to stay steady, but again, sometimes
10.
you have to move a little bit to stay off the wall of the vessel.
Thank you.
10. 10.
So we're a little different here. I mean, we'd like to see within 1 or 2 of our initial reading, but
9.
oh, there we go.
9.
So if you're seeing some inconsistent numbers, would you do
9.
more than 3?
Yeah, we have sometimes. I mean,
9.
we try not to play with the numbers too much, but yeah, we want them to be consistent. So should I switch over? I think that's a portal vein branch up top. I can quickly do that.
Sure. So we have a number of 9 and 7 from the hepatic vein. Looks like the middle hepatic vein.
I withdraw a little bit slowly, but I don't worry too much because with it being a 25 gauge,
No need for color, flow, non-withdrawal.
I think at the beginning I was, and then I stopped because I've never seen an issue. I don't know if other people could fill me in if that's something they do. So I'm going to zoom up here. Oh yeah, that's a good point to show.
We'll see, looks like with Doppler signal, we're in a venous structure, looks like portal vein, so we'll turn that off.
We should do that one more time though, because we forgot to show that earlier. For the hepatic vein, you get that, you should see more of the waveform. It's getting the cardiac waveform.
Can you describe that a little bit more with Doppler signal in the hepatic vein, what it is that we're expecting to?
Well, normally in a vein you'll have just a kind of a steady, continuous flow like this, like you're seeing in the portal vein, but because the hepatic vein is communicating directly with the heart, you'll see more of a waveform.
We have a question from the audience about using shear wave for liver analysis in addition to PPG and liver biopsy. Do you incorporate that into your practice for endohepatology?
You know, I haven't yet. You certainly can. I just in our institution, the patients usually have already had that done by the hepatologist. You know, in the various ways that they do it. They have fibroscan in the office. They get MRI, elastography. So I haven't, but
they usually come in with information already.
Yeah.
So you're getting ready to puncture the portal vein. Is there a difference in the feel of the vessel? Is it more difficult to find the portal vein than the hepatic vein in the human?
In the human, it tends to be a little bit, you know, we kind of go for the central portal vein, and it tends to be a little bit farther away from the scope. Now my needle's not coming out. There we go.
Is it transgastric, transduodenal?
Yeah, I'm doing all of this transgastric. In rare cases, I've gone, if the portal vein is from the transgastric approach is very far away, I've gone with a transduodenal approach. I'm a little off here. Let's see where we are. So what Phoenix asked earlier about having some liver parenchyma, this might not be the best area because this is sort of extrahepatic. So here we're back with some liver parenchyma there.
I always like to try to give as much liver tissue in between so that we have more to tamponade as the needle comes out.
So I thought earlier I had a very good window and I sort of lost it, but the portal vein, sometimes I think the wall's a little thicker and you need to puncture a little harder. That's not really the issue. I'm just not seeing my needle right now.
I think we've demonstrated very well. We'll continue to do your work. Thank you so much for the
Thank you.
session.